Welcome to the Only Healthcare Podcast. I'm Randy Vogenberg here with my co-host, Michael Navin, and our special guest, Murray Harbour. Murray, welcome. It's great to have you on the Only Healthcare Podcast. Murray is the founder and managing director of Healthcare Disruptions and executive director of the Mississippi Business Group on Health. You want to just do a brief background and intro for our audience, Murray?
Oh, sure. Well, first, thanks for having me on, Randy and Michael. I appreciate it. I always enjoy your podcast, listening to different episodes. Murray Harbour, as Randy says, I wear several hats, but I have over 30 plus years in employer health management and running programs internally as well as working externally. And then creating a coalition in Mississippi of employers to actually put more best practices in place, put more value-based benefits and care designs into place, and to actually put things together that actually reduce cost and improve health outcomes.
Well, great. Thanks for that, Murray. Today we want to talk about what's happening with value-based services for employers and get into some of the advanced primary care, direct primary care, and other value-based solutions or health and well-being solutions that we're seeing in the commercial marketplace in particular. So, Murray, what have you been seeing in 2025? What's different from the last couple of years coming out of the pandemic?
You know, I think you're starting to, with rising premiums, and we're seeing record renewal rates this year. You're seeing employers take more of a, they're controlling it more. They're actually taking a lead and working with their vendors to make sure that they are getting the best value for their investments that are there. They're working to actually find solutions out there in the marketplace, not just third party, but with direct contracting with provider systems. I think you're starting to see more primary care, which we'll talk a little bit more later on, that are kind of seeing the light. They're getting tired of the third party care delivery systems, such as on-site, near-site clinic vendors, and they're like, we need to capture some of this back into their system that's there. We're seeing more performance-based disease management in the marketplace. I think you're seeing alignment of pharmaceutical and care delivery together in more value-based options.
Just a question, is there evidence that shows that stronger primary care investment lowers the overall employer plan costs rather than just shifting the spend upstream?
Yeah, there's a lot of research out there showing that you have a quality primary care visit and you get people into those quality primary care visits, it does reduce the emerging high cost claimants that will be your high cost claimants later. Having primary care, what happens is people avoid care, especially males. They avoid the care, so they wait until something happens to really seek care. So having a good, robust primary care that engages people at the spectrum, keep the healthy people healthy, get those emerging costs healthy, and then find those that are out of control and get them into programs and services that actually can moderate the cost but help them with their outcomes.
So are they looking at is there an ROI that they apply against something like that to see what impact it's having?
You know, everyone talks about ROI and you're always going to try to look at it. And really you're looking at VOI, the value of investment that's out there, not just a direct cost change. Because if you take someone that's apparently healthy and low cost and you keep them low cost, you really can't track that, right? I mean, well, you can track it, but you really don't see that it's saving you money. What you can do is save that creep up. But you're seeing, I think when you look at emergency room visits, when you have a high quality primary care visit, you can reduce emergency room visits by 50%. You can reduce hospitalizations by 80% by catching things early, getting them engaged as a patient and civilizing them as a patient to make sure they are managing their issues, their risks in an appropriate way.
So, Murray, would you say that we're kind of going back to where we were pre-pandemic in terms of recognizing the value of health and well-being services, particularly preventative care?
Yeah, I think, having been a long-term wellness director, wellness has gotten a bad name, right? So, and there's a lot of bad players that promoted a lot of national ROIs out there that really weren't getting the ROIs that they were promoting. So I do think we're moving back. During the pandemic, we saw definitely with more COVID type of issues, and we're seeing more health and safety issues that now with the remote workforce, we're seeing the creep up again of rising claims. But that's why I think employers are saying, wait a minute, we've got to stop this. And how do we better manage it by looking at what's working? And in the coalition world, you've got your innovators and early adopters that are using these strategies. And I think that's one place, no matter which part of the country you're in, that you can look and see what some of the innovators are doing to better manage costs. And really, it's about getting people into care right away and making sure they become a good patient.
So what has been the uptake on direct primary care? I know that the number of practices has increased on a national basis, but what's the reality at the street level?
When you look at direct primary care, that's normally to me a consumer model that people are paying a membership fee to go in and see things. When you look at advanced primary care, that's more of an employer model where you're prepaying for a group of people that's there. But I think it's showing the value of primary care in that it doesn't cost as much to get people into primary care. And one of the reasons people don't go to their physician is they're afraid of the cost. They're afraid they don't want to pay the copay. They don't want to, even though their annual physical is covered 100%, they still see that as a barrier. We find access to care. Sometimes it takes 2 to 3 months to get into a primary care, right? So when you have a direct primary care relationship or an advanced primary care relationship, you can get in sooner and get in and you can come in as much as you want. So I think that changes the mindset of the employees if it's marketed and promoted properly.
On that point, why do you think employers are interested in bypassing the traditional network for primary care?
I think employers that have been trying strategies for many years and some of those strategies are not working out to the best outcomes that are looking at what are other ways. And I think they're starting to get sold into the prevention mindset that, hey, if we can get people in early and get them to the right care that they need, or deliver the medications through the clinics, like they do in advanced primary care and direct primary care, and they don't have to go from here and do a referral here and do that. The patient in the whole traditional billing system is a wait and see, here it's referred, get you over here, we got to wait. All that time lag really takes a toll on the patient and the person. And it's like they get tired of the game of it. And then they see the costs going up and they're like, I just stay away.
So what have been some examples of the models that you've seen with the advanced primary care with the employers in particular?
Yeah, I think we're seeing different groups out there from advanced. There's third-party vendors out there that have employer clinics, whether it's an on-site or near-site clinic, that is pretty much a advanced primary care model. That's been it's grown over 30 years. I remember putting my first clinic in 2000 in Minnesota, and it's been growing ever since. But now we're starting to see provider systems and actual independent physician associations and some primary care groups actually package these services. That for a long time they fought them, they lost business, and they made fun of them. But now they're actually starting to kind of embrace it and try to understand it more. And when they find out that one of the barriers is they don't have access to the claims data to actually see the full picture of the patient. So now with these advanced primary care, they have systems to be able to look at the claims, to mix with their EHR data, to actually do better patient care by knowing more about them, to make sure that, and they can manage that process better. The more that the provider knows about the patient and where they're getting care and what they're being treated with, the more informed the provider can be, and they can do direct care, more effective care in that high quality visit.
So we've been talking about where we're at today, kind of how we got to where we're at today. What other changes have occurred in the last 12 to 18 months before we start talking about where we're going?
Well, I think we've been in a wait and see since COVID. I think there's been a lot of issues affecting employers, and what I think, Randy, you and I talked about this several years ago, is that employee benefits took third and fourth they were in the third and fourth rung for a while because people were dealing with the COVID. They were dealing with attraction and retention of employees. How do they handle remote workplaces? How they look back in the DEI, and then benefits was the third or fourth area they were looking at. And I think now it's popped back up there again because some of these other issues have gone away or suppressed to where now employee benefits, and we're seeing these larger renewals that they're like, okay, we got to get back to this and figure out what we can do, because we can't keep paying double-digit costs every year, and no matter what, even if they have a high turnover, they still don't want to pay double-digit costs.
Interesting.
Do you think there's legislative issues that impact that as well? I know when you think about the medical loss ratios and things of that nature, perverse incentives, if you will, does that have an impact on the employer on the negative, or does that help?
Oh, I think that has. I think there's two parts of that. One, I do think that when you look at the way typical plans run, they have shareholder value they have to show. So they're really not incented. The incentives are not aligned for the most part. But when you look at the self-insured world, their incentives are more in line, that they can take when they take a supply chain approach to say, okay, how can I manage this and not rely on the current system which to me is full of waste and unnecessary care, and the billing system and chasing, the bills. It eats a lot in the system. I think you're seeing a lot of changes. You hear a lot about transparency in the marketplace, whether it's hospitals or pharmacy and everything. And I think those legislative initiatives are okay, but at the end of the day, the consumers are not good consumers of healthcare. They're good consumers of going out to eat, and they're good consumers of buying a car, but not of healthcare. And in all these legislative reforms of creating these systems for people to become good, look at transparency data, to look at even consumer-directed health plans, have failed, because we're relying on that consumer to be a better consumer than what they're willing to do. And I think no matter what legislation happens, I think it comes down to employers putting together the appropriate level of self-insured plan for those that are self-insured, and communicating and engaging their employees and family members that are part of the plan into those resources effectively. And I think that's the growth area. I can't go every conference I go to, we hear about engagement. How do we get employee engagement? How do we get engagement in the benefits? How do we get engagement, so that way we can get people to utilize what they offer to maximize their total compensation. And so that's my view on the legislative piece.
So, given what you're hearing and seeing at all the conferences this past year, are there changes for 2026 that you're anticipating to see happen or put into play?
I'm seeing more. I'm seeing people. Let's take GLP-1s, right? That's hit a lot of plans, high cost. But what they did is they implemented without the wraparound programs, the effective programs, to make sure the people that have the risk, that need it, get into it and actually follow a plan that mixes the services and the pharmaceutical together. So I think we're going back to seeing more bundling of services for particular disease states out there. And you see the metabolic cascade out there. We're seeing orthopedic bundling go on, and programs using technology that's out there. And those are two areas where I'm seeing a lot of growth with employers adopting and packaging and just really trying to do their best part with those areas. And I think there's a lot of learning that's happening, not just with the employers, but with the brokers and consultants. They don't always know what is best, and their incentives aren't always aligned either. However, it's with the renewal rates now, it's putting a lot of pressure on them to actually implement a lot of these solutions, and for the employers to ask the questions, which they can, of saying, how are you getting paid? And we're paying this, but are you also getting paid by on the other side as well? And I think it's opening the door to people realizing, well, wait a minute, who do you work for? Do you work for us, or do you work for the vendors? And I think that's a good thing that's happening in the marketplace, is people are starting to question those relationships and to get more, I guess, solid in what is happening with their dollars and their relationships.
Yeah, I mean, on the pharmacy side, I operate another business on the pharmacy side, and the issue is a lot of them are hamstrung by the PBM contracts, and the PBM contracts are telling them you can't shop outside of the PBM for a drug, which is communism to me.
Right.
But
that's true.
But so the awareness that the decision makers at the employer level have to take into account for is understanding what's in these contracts and how can they push back against them, right? To be able to say, look, we want you to be our PBM, but you shouldn't control every penny of every drug spend that happens, because I want to provide transparent technology to my patient, and I want them to be or my member, an employee, and I want them to be able to shop if they can shop. So it's just having that awareness, I think, too, around being able to understand what's in those contracts.
That is one of the biggest barriers for employers to implement said strategies. However, I am seeing some of their let's take a clinic vendor, an employer clinic vendor, who are packaging in programs using the medications like through Lilly Direct or Novo Direct in those pieces matched with their services, so they can actually bundle that together because it's a third party entity piecing it together. They can actually provide that as part of their service delivery.
Yep.
So we're seeing some workarounds. As I say, when I used to coach in college, the NCAA playbook was like this. Now it's like this because people found out all the workarounds. So I think there's some good solutions out there. And, Randy and I have had multiple conversations with some of these GLP-1 manufacturers on how do you package these and not necessarily break that contract, but how can you actually get it to people by working with other vendors.
Yep.
Yeah. So this whole issue of engagement, and we have now the multi-generational impacts the employers are feeling, but based on some of the recent reports coming out, surveys from various business groups around the country, benefits are still a strong, attention grabber for people seeking employment. They want to know what the benefits are and so forth. And with the younger population, not as many disease states, but certainly prevention is still a primary issue, along with family building and other types of younger person issues that they have to deal with. So when we start looking at this whole journey around prevention and all the different types of issues and opportunities that come up, do you see the employers beginning to respond to that need that's growing within their employed population?
Randy, good question. I see it trickling. I don't see it. It's not an open faucet. People are not just running to it. It's taking time. As you know, in the coalition world, they are some of the leaders and innovators and do things, but still, that's a small amount of the total employer population in the country. The more need to take note to actually build their programs more in a self-insured. They like the idea that self-insured models can reduce their costs, but they don't want to put the plan management in place to actually do things. And with the younger, to your point about the younger generation, we've seen a growth in the fertility area, right? And some of those programs go into employers and to be able to say, hey, we can help you with your fertility benefits. A lot of the younger employees are asking about wellness programs again. What do you have for me as I want to work from home, I want to do this, but what are you doing for me to help keep me healthy and well and give me discounts in the world to so I can stay healthy and well. So you're seeing, I think it is a big change over with the generational influx of younger folks into the workforce, and they're happy with an app. They're happy with telehealth. They're happy with engaging through an app with their providers. They don't have to be geographically or location specific to access any type of health and health care that's there. And I think that's changing the landscape a lot. I was on a call yesterday looking at what do they think about structured physical activity that's becoming a benefit within health plans, and do you have to be on site, or is this something that can be delivered virtually and even in a group setting virtually, much like group diabetes sessions are being done now. So I think we're seeing a big change I think this generation is changing the way benefits are done. think this generation over the past 5 to 6 years that I've seen is getting employers to actually think differently about their benefit strategy. And it's no longer just wait and see, here's the basic cookie cutter you do. They're having to think outside of the box a little bit into thinking differently and offering different options.
Yeah, I guess listening to what you're describing that's happening in the market, it's always slow to change. It's more of a trickle than a fast river flow in terms of adoption by the consumers, which is the employed population that we're talking about in this particular case. But as we're now in the planning season for 2026, 2027 benefit designs, are you seeing the employers really changing the design and some of these planned benefits that you're talking about? Are they looking towards 27, realizing they've made modest changes if they did it all for 26?
Again, I think it's a small amount that are really taking a deep dive into it. There's a growing amount actually looking to maybe thinking about how they're changing, moving back away from consumer-driven plans to let's do this plan if we can capture everybody in, but let's make sure we have some key elements in place, such as the primary care, right? Advanced primary care in there, and certain disease states, and as you mentioned earlier, fertility and focus. So I think you're seeing them think a little differently. There's a growing number of employers thinking differently, but they're going to focus on 2 to 3 areas at a time. Very few employers have I seen look and say change the whole thing and put all these solutions in place in 1 year. Okay, even Russell DuBose down at Pfeiffer in Birmingham, Alabama, my hero these days. He actually put his own clinic in, not third party, his own clinic. He did direct contracting with the local hospital systems and imaging systems. He wrote his own PBM contract, okay, and put things in place. And they're saving so much money that he asked employees, if we save money doing this, what would you want? They got increased salaries, more retirement, and they put money into scholarships for their employees' kids for college, right? And it's wonderful. I mean, it's a perfect model of how an employer can do it. But he didn't do it overnight. He built, take 3 to 5 years, built it, and now he's got a nice system going that's actually, he's reduced his cost by half, I think, and over time, and those dollars that are there, he's repositioned properly.
And he's fully funded or self-funded?
He's self-funded. Self-funded.
Yeah, so
most all this is self-funded.
Yeah.
Fully funded, you're relying so much on the carrier.
Yeah, the premium.
And that most of the time, a small company, is going to be fully insured, and they're just trying to stay afloat,
right,
in what they're doing from their margins and what their industry is and what they're doing. But as you get grow over the 50, you're seeing a lot more that are 50 and to 100 now becoming self-insured and doing things, and that's with they're participating in captives as well. So they're actually managing the reinsurance by participating in captives.
Yeah, we continue to see more looking at the self-funding option instead of fully funded because of the costs and not getting the value that you were talking about earlier. So that trend has not slowed, which I was a little surprised by looking at the latest statistics. But we'll see what happens going forward. There's so many moving parts. But getting back to this whole primary care prevention thing to kind of tie it together to wrap up this episode, where do you think we're going to be in the next couple of years with this whole advanced primary care, preventative care, well-being trend that we're seeing in the commercial employer space?
You've seen a lot of the primary care groups across the country have gotten gobbled up by health systems, right? We're starting to see some unbundling of those. They're spinning back off to do their own thing for many reasons. And, there's a specific group in Mississippi, it's called MEA Medical Clinics, and they spun off of the Catholic Hospital, and they're like, we have a great name, we love our community, we provide great care. Now, they lost business to some of the employer clinics that they said, hey, we want to do this ourselves. So they started offering their own advanced primary care model without knowing it to their own employees. And in 2 years, and they have 180 employees with 500 lives in their plan, and they saved $1.5 million by doing the all advanced primary care. And they're going out to marketplace, right? And these are providers that are well known, and they like the model now because they're going to get a prepayment model. They're packaging their services for occupational health, for primary care, and some urgent care, all under one fee to do things. And they're liking the fact that they can use software to look at the claims to better manage the patient population. So they're actually loving it because they don't have to build a clinic. They already have clinics there. So any revenue coming in is actually more revenue for them. But they like the fact that they can get more information to better manage the patient and get them in because they already have a relationship with the families that are there. And that's where I think we're going to see more of that, Randy and Michael. I think you're going to see more primary care groups kind of say, okay, we can adopt this model. We can work with our local community employers, no matter if it's a small employer or a large employer, and actually manage care the way it should be done. And I'm kind of excited about it because while I put some of the first on-site clinics in the 2000s, we did that because the primary care and the health systems didn't want to take a upfront fixed cost payment, right? They just wanted to generate the bill and chase the dollars. So I really believe you're going to see more and more of these value-based care initiatives with primary care and extend programs off of there, such as the metabolic health pathways, physical therapy, mental health. That's going to be done there, and quit doing the billing game. I think the billing system is one of the worst things that's out there. But the more that you can move people to bundling and patient care and not trying to maximize their dollars, through the billing system and get rid of waste and unnecessary care, and the billing system itself is waste. And it's not going to go away, but if you can mix the two and mix some of these other services like Oct Health and urgent care together, you're going to get people into prevention mode. That's going to keep that emergent cost from going up, and that's what everybody's looking. That's where the costs come from. Is that 30 to 40% each year? That's people that are out of control diabetics, people that are letting multiple comorbidities happen, and they end up going to the emergency room, or they go to ER. They go to urgent care, and they just eat up a lot of costs. Yep. So the more we can get them managed into primary care, the better. So I'm excited about programs like the MEA medical clinics. I think there's other groups out there looking to do that across the country. In California, I know of, and Rhode Island, and New York, and I think that's going to be exciting.
So summarizing it is keeping it local, right? Keeping it high touch, almost creating a personalized health with that primary care as the quarterback of all the health for that particular patient, and then being able to have the coordination with the specialists in the area, as needed. That kind of. That's
right. Exactly. Everything you said is right on point, Michael. And I think we push the annual physical exam a lot. And, there's a Harvard study that came out 10 to 15 years ago that said, maybe people in their 20s, 30s need to come in every 2 to 3 years. People with a low total body risk score, maybe they only need to come in 2 to 3 years. You don't have to go every year, But as you get older, you need to come in more if you have certain risks. So I think when local providers can manage risk better, understand how to manage the risk better, that's just going to make all the difference.
So once again, we're back to the future in medicine and trying to shift how we improve care where it makes more sense. Great. Well, appreciate you joining on the Only Healthcare Podcast, Murray. It's always great talking with you and learning from you, sharing the ideas that you're seeing out there in the marketplace. And we look forward to having you back on our Only Healthcare Podcast. For our audience,
thanks for having me.
Please check out our onlyhealthcarepodcast.com. Our new website should be up. And give us feedback, give us ideas, suggestions for topics, suggestions for guests. We look forward to seeing you on the next Only Healthcare Podcast.
Thank you for tuning in to the Only Healthcare Podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.